Welcome to Next Chapter Retirement, the podcast where we discuss smart strategies for building and protecting wealth, health, and well-being, helping retirees shape their next chapter into the best chapter. I'm your host, Mark Erickson, and each week we help you navigate the big decisions that shape your future, from health and financial planning to Medicare and lifestyle design and everything in between. Let's dive in.
Fidelity just released their 2025 estimates, and I'm just going to warn you, the number stops most people cold.
Oh, yeah. It's a heavy one.
Right. They are projecting that an average 65-year-old retiring today will spend $172,500 on health care over their retirement.
Yeah, and if you're looking at a couple, it's $345,000.
Which is just, it's staggering.
It is. And, that actually represents a 4% jump from the previous year.
Yeah.
So the trajectory is just as vital to understand as the baseline number.
Wow. Yeah. So the costs are just moving aggressively upward.
Exactly.
Well, welcome to today's deep dive, everyone. That $172,500 figure is really the cornerstone of our discussion today. We're pulling our insights from the Next Chapter Retirement podcast.
Which is a great source, by the way.
Yeah, really fantastic material in there. And our mission today is basically twofold. First, we are going to uncover the 5 hidden healthcare costs that consistently blindside retirees.
The surprises, right?
Right, the nasty surprises. And second, we want to extract the actionable retirement budget strategies from this source material so you can build a comprehensive game plan.
Because, people will agonize for months over their Social Security claiming age. Right?
Oh, absolutely. Constantly tweaking their investment mix.
Right. And then they treat healthcare as an afterthought. They just assume, hitting 65 and getting that Medicare card is essentially like receiving a magic wand.
A magic wand that makes healthcare a non-issue. Okay, let's unpack this because the danger of that assumption, it really cannot be overstated.
No, it can't. Original Medicare was designed to be a robust safety net, sure. But it was never intended to be this, impenetrable financial shield.
It leaves deliberate gaps.
It's very deliberate. And those gaps are exactly where the most severe financial surprises live.
So let's look at the actual mechanics of Medicare, starting with surprise 1, the baseline costs, because it is definitely not a zero out-of-pocket landscape.
Not at all. Let's look at the cold, hard 2026 numbers. So for Part A, which is your hospital coverage, the deductible is set at $1,736.
Right, but I was looking at the structure of this, and the catch is that it's tied to what they call a benefit period.
Yes, exactly.
It's not an annual deductible like, the insurance most of us are used to.
No, the benefit period is a fundamentally different mechanism. It begins the day you are admitted as an inpatient.
Okay.
And it only ends when you haven't received any inpatient care for 60 consecutive days.
Wait, so if I go into the hospital in February, I pay that $1,736 deductible.
Right, you pay it, you recover it, you go home.
And then, say I have a completely unrelated health event in October and I get admitted again.
Well, because it's been more than 60 days, a brand new benefit period triggers. You owe another $1,736.
Man, that structure seems almost designed to catch people off guard.
It's a major blind spot for a lot of folks.
And the liability just escalates if the hospital stay stretches out, right? Like the source notes that for days 61 through 90 in a hospital, you're paying $434 a day in coinsurance.
Yeah, per day. It adds up incredibly fast. And then you have to look at Part B, which is the bottomless pit.
Right, the medical insurance for outpatient care and doctors.
Exactly. You've got a monthly premium of $202.90 for 2026, plus its own deductible. And then you hit the 80-20 cost-sharing split,
where Medicare generally covers 80% and you're responsible for the remaining 20%.
Right.
I really want to focus on that 20% for a second because, 20% sounds like a neat, manageable slice. But under original Medicare alone, there's no annual out-of-pocket maximum on that.
None. Zero cap.
It feels like handing the healthcare system a blank check. If you face a serious illness, 20% of infinity is still infinity.
That's a perfect way to put it. The lack of a cap is this legacy of how original Medicare was drafted back in the 60s.
Right. Medical technology was totally different then.
Exactly. It simply couldn't keep people alive through the kinds of chronic multi-year conditions we see now, so the costs weren't compounding into the millions.
But today, specialized medicine can bankrupt someone through that uncapped 20% in just a matter of months.
Which is why people buy Medigap policies to put a ceiling on it, or they opt for Medicare Advantage plans, which legally have to have out-of-pocket maxes.
So the core strategy here for you, the listener, is really a mindset shift. You have to proactively budget for premiums, deductibles, and cost sharing.
Yet you simply cannot plan a retirement budget assuming healthcare operates at zero cost.
Okay, so moving from acute medical care to surprise two. Routine physical maintenance.
Oh, this one always shocks people.
It's endlessly fascinating to me that original Medicare completely ignores the tools we use to interact with the world, our teeth, our eyes, our ears.
Yeah. What's fascinating here is how Medicare draws the line between medical necessity and routine care.
Even though they're all part of the body.
Right. But routine dental, vision, and hearing are universally excluded. No cleanings, no fillings, dentures, routine eye exams, none of it.
And the historical context from the source really explains why, right? During the 1965 debates, dentists and optometrists lobbied aggressively to stay independent.
They wanted to preserve their autonomy. But the unintended consequence decades later is a system that essentially treats teeth and eyes as, like, luxury accessories.
It's such a massive structural blind spot. Like, Medicare will happily cover your cataract surgery because it's a medical necessity.
They'll even throw in one pair of glasses post-surgery.
But if you just need an eye exam to update your progressive lenses, you're paying out of pocket.
Exactly.
And no hearing aids, which hearing aids alone can easily run into the thousands of dollars.
Oh, easily. And the irony is that seniors inherently need more of this sensory support as they age, not less.
Right. The deterioration of vision and hearing correlates directly with loss of independence.
And cognitive decline, too. Yet the financial burden rests entirely on the retiree.
So the actionable strategy our source outlines is highly pragmatic. Build a recurring line item in your budget specifically for dental, vision, and hearing.
Yeah. Treat it as predictable overhead. You can use standalone plans or look into Medicare Advantage bundles, but, and this is crucial, read the fine print.
Because Advantage plans often have strict annual limits, right?
Yes, very strict limits, and their provider networks can be incredibly narrow. You really have to calculate if the bundled benefit actually covers what you need.
Got it. Okay, so we've established the physical maintenance costs, but let's pivot to the chemical maintenance. Prescription drugs, which is surprise 3.
The pharmacy roller coaster.
Yeah, because a hospital stay is usually a singular event. But prescriptions, that's a lifelong subscription.
It really is. And healthy 65-year-olds often fall into this trap where they look at their tiny, generic pill box and assume that's all they'll ever need.
Right, they extrapolate a few pennies a day across a 30-year retirement.
Exactly. But new conditions arise. Suddenly you're prescribed a brand-name drug with no generic, and you're staring down a bill of over $1,000 a month.
It's a constantly moving target. But here's where it gets really interesting. Our source highlights a massive shift happening in 2026 for Medicare Part D.
Oh, this is some genuinely good news.
Yes. We finally have a hard annual out-of-pocket cap set at $2,100.
It's a monumental piece of legislation. Once you hit that $2,100 mark on covered meds, your plan picks up 100% of the cost for the rest of the year.
Wow.
And that applies whether you have a standalone Part D plan or an Advantage plan.
So I was looking at that, and my instinct was, great, I'll just set my budget at $2,100 and forget it. Can't we just do that?
I wish. But no, the caveat is that the ceiling resets every single January.
Oh, right, the annual reset.
Yeah, so if you're on expensive maintenance meds, you are climbing that $2,100 hill every single year.
Can't just budget for it once.
Nope. And you also have to watch out for formulary changes. A plan might price your meds beautifully this year, but you drop them entirely next year.
Which means you absolutely cannot get complacent. The strategy here is using the fall review window every single year, right?
Yes. 5 minutes a year checking the Medicare Plan Finder can protect real, measurable capital. Pricing changes annually.
You have to check if your specific medications are still covered. Okay, so we've covered medical, routine, and pharmacy, but now we have to address the elephant in the room. Surprise 4.
Long-term care. The big one.
Right, because that massive $172,500 fidelity estimate from the intro, it doesn't include a single dime for long-term care.
$0. If we connect this to the bigger picture, roughly 70% of people turning 65 will need some form of long-term care.
70%, that's a probability, not just a possibility.
Exactly. But people confuse medical care with custodial care. They assume Medicare will handle it.
Right, they hear care and think Medicare.
But Medicare almost exclusively pays for short, skilled medical stays. It's designed to cure or rehabilitate an acute condition.
whereas long-term care is custodial. It's help with bathing, dressing, eating.
Right. And even when Medicare does cover a skilled nursing facility, it's incredibly narrow. Days 1 through 20 might be fully covered, but days 21 through 100, that'll cost you $217 a day in coinsurance.
For 2026, yeah. And after day 100, coverage terminates completely.
Completely. They do not fund the years of daily custodial assistance.
And the 2025 price tags for that are just terrifying. A private nursing home is $355 a day. That's $129,000 a year.
Yeah, and a semi-private room is still $115,000 a year. Even assisted living is about $74,000 annually.
Okay, those facility numbers are horrifying, but my plan is just to age on my own couch. Staying home is the ultimate life hack to avoid those fees, right?
I hate to burst your bubble, but no, that's a huge fallacy.
Wait, really?
Aging at home is a luxury, not a discount. Because custodial care doesn't scale. You're paying for dedicated one-on-one human time.
Oh, right, because in a hospital, one nurse monitors multiple people.
Exactly. But private duty nursing at home, that's roughly $90 an hour.
$90 an hour.
Yeah. If you need substantial daily supervision, that eclipses facility costs very quickly. Even adult daycare is $95 a day, which is $25,000 a year.
Wow. So what is the actionable strategy here? Just cross our fingers.
Definitely not. You have to decide on a plan before a health event removes your options. Once you have a stroke or a dementia diagnosis, you can't buy insurance anymore.
Okay, so you have to do this while you're healthy. The source lists 3 paths, right?
Path 1 is self-funding, earmarking specific assets, like a brokerage account, just for care.
Path 2 is transferring the risk to an insurance company.
Yeah, traditional long-term care insurance or hybrid life and annuity policies.
Where if you don't use the care, your heirs get a death benefit, so it doesn't feel like a total sunk cost.
Exactly. And the third path is a combination. Buy a smaller policy to cap the catastrophic tail-end risk and self-fund the first few years of home care.
Just consciously choose a strategy. Don't default to assuming the government has your back. Okay, we have one final surprise. Surprise 5. Because all of these rules, Medicare, the gaps, the caps, they revolve around age 65. But what if you want to cross the finish line early?
Ah, the early exit penalty. The gap before 65.
Like stepping away at 60.
Leaving an employer plan before Medicare kicks in can be the most expensive stretch of retirement. You're fully exposed to retail health insurance costs.
Right, and the options are pretty limited. You've got COBRA, which is notoriously expensive and time-limited.
Or a spouse's active plan, if that's an option.
Or individual plans on the ACA or Obamacare Marketplace, but the nuance there is huge, right?
It is, because individual plan pricing is tied to your income.
Yeah.
Specifically, your modified adjusted gross income, or NGI.
So managing household income in early retirement can trigger massive subsidies or completely disqualify you.
Right. If you pull heavily from a traditional IRA to fund your early retirement, you inflate your MIGI. You could lose your subsidy and add thousands to your expenses instantly.
So the strategy is to map your health coverage from your last day of work to your 65th birthday before you hand in your notice.
Please do it before. Retiring on a Friday and trying to figure out health insurance on a Monday is a disaster.
So what does this all mean? Let's synthesize the master game plan.
Let's do it.
The overarching lesson here isn't about being rich, right? It's about seeing the costs coming.
Visibility is everything. It turns a crisis into a manageable expense.
You have to budget healthcare as a real, concrete line item. Plan for the Medicare gaps. Deliberately budget for your dental and vision.
Expect rising drug costs.
Yes, expect them and use that fall review window every year. And deliberately choose a long-term care strategy now. We want to give you the map you need to confidently author your next chapter.
You know, this raises an important question, though. A really structural one.
What's that?
If the biggest threat to our retirement budget isn't a sudden illness, but simply the day-to-day custodial cost of living a very long life, do we need to fundamentally redefine how we view healthcare versus life care in our culture?
Oh, wow.
We save so much for clinical treatments, but we will leave the actual mechanics of living safely in our final decades up to chance.
That is a profound distinction to leave everyone with. Healthcare versus life care. You have the tools and the map now. You just have to be the architect of your own safety net. Thank you so much for joining us on this deep dive. Keep asking those big questions, and we'll catch you next time.
Thank you for listening to the Next Chapter Retirement Podcast. Please like and subscribe and share this with anyone planning their next chapter. For help navigating Medicare, you can find helpful resources and connect with our team at nextchapterpod.com. Until next time, plan wisely and live fully.